A very good afternoon and good evening, everyone. I am Dr. M. Shreya Jaiswal, currently pursuing PhD in oral and maxillofacial surgery from Busan National University, South Korea, and I'm the host for today's session. Today we have Dr. Varunraj Kamat from India with us. He is a distinguished dental surgeon with a private practice dedicated to implant dentistry, full mouth rehabilitation, digital smile design, and TMJ therapy. He is the pioneer of the KISS philosophy in implants. It means keep it safe and simple, a treatment ethos that has resonated with practitioners seeking predictability and long term success in implant dentistry.
Thank you, ma'am. Thank you for the elaborate introduction. And if you may allow, I'll just share the screen and we directly jump on to our presentation for today.
Yes, please.
Yeah. Okay. 2 minutes. I'll just move the taskbar. Yeah. I hope my screen is visible now.
Yes, yes.
Yes. So, a very warm welcome on a rainy Wednesday evening. Unlike it's a summertime in India, but we are expecting thunderstorms and rain over here. So, to all my international delegation as well as my Indian delegation, a very warm welcome and a good afternoon on a rainy Wednesday evening. So, let me introduce today's topic, and it's the most dreaded but a dry topic when it comes to dental implantology or in dentistry. It's occlusion, and most of us would always give it a skip when it used to come to our examination as well. Because reading occlusion, we always go off to sleep, and it's an afternoon session. So I hope I keep you guys in your seats for a long time. So, why occlusion plays a very important role in your dental practice? So, basically, when a patient walks into your clinic, 10% of patients usually come for their aesthetic needs, while 90% of the patients come when they do not have teeth or they have some biting problem. And this is where we have to give them teeth, either by a bridge or a denture or an implant, just for them to eat food. And imagine if we do not give that bite well, what will happen? The patient will always come to us seeking some or the other help. Can you just trim this crown? Or I'm not feeling it the way I have to eat. I cannot eat this food. I cannot eat soft food. I cannot eat hard food. And eventually marry that patient for a long time, though that marriage survives for a long time, but it always with a fights. So what it is, occlusion is the key towards a long-term implant success or any prosthetic success. So let me take you to a triad, and this triad is something when a patient comes to us seeking for a dental implant. The most important part in implantology lies in the planning. Why planning is important in implantology? Because it is always a reversible science. You always have to see something before you even place an implant, and that is your how your tooth is going to come in your mouth. Nowadays, because of 3D planning, virtual setup, we can actually plan occlusion in patient's mouth. We can plan a teeth setting in patient's mouth, and we can plan how we are going to place the implants in those key areas. That is where you plan your occlusion. So implants is always a science where you foresee what is going to do, and then you plan it, and then you do move on towards a surgery. So that is where your implantology lies. Planning is very important. At the stage of planning itself, we need to understand the key factor, that is occlusion. So the tip of the Everest is always occlusion when it comes to implantology, because a lot of studies say that the survival rate of the implant lies on its occlusal plan. Because what happens is we have natural tooth, we can overuse them, we can abuse them, and they stay there and they are very much in our mouth to take all the inserts. But implant is something which is like a foreign body and it cannot tolerate the inserts. Imagine a person in your house staying with you, you fight with them, but still you love them a lot. Imagine a person who's coming in your house as a guest and you fight with them, what will happen? Is implant. So why it is important in a practice? So in a dental practice, it is based primarily upon the relationship it has within the interconnected biomechanical systems. Which are these biomechanical systems? We will see in the next slide. So when it comes to occlusion implant, so a biomechanical system of three parts: the teeth, the periodontium, and the articulatory muscles. I hope everyone knows that we have muscles of mastication which help us bite. And what this bite is, it is occlusion. The teeth are taken care by the periodontium. So let me just revise with you what exactly the basics of occlusion is, and then we go ahead and jump on implant occlusion in the part B of my lecture. So let us understand our articulatory system is governed by three parts: teeth, periodontium, and the articulatory muscles. So a change in any format on the teeth can lead to change in periodontium as well as articulatory system. A basic example: when you give a crown on a tooth, a root canal treated tooth, the patient comes to you for a long time saying he has got a high point, which we kind of trim it. We trim it until we see the, you can say, the metal portion if we are giving a DMLS or a PFM crown. And eventually, this patient is lost in the universe. What exactly happened? The periodontal ligament got adjusted to the bite. The periodontal ligament are the elastic ligaments across your teeth which stretch and they go away from the traumatic bite. We feel okay now, my patient has settled down since I've reduced the bite. No, it's the biomechanical system in the body which takes over and takes care of that tooth. Similarly, any change in the periodontal ligaments, maybe a periodontal link disease, can change your teeth as well as the muscles. And any change in the muscles, so most of the TMJ patients, there is always leads to change in the teeth and the periodontium. So our masticatory system plays a pivotal role or a very important role when it comes to taking care of occlusion. Always see to it, and right now talking with respect to natural teeth. Once I finish the basics, we'll jump on to the implant occlusion. So a temporomandibular joint acts as a hinge. Your opening and closing. We always say that TMJ gives a hinge motion. What are the muscles help in? The muscles helps as a motor. They help the TMJ to move from open, close, or protrusive, lateral or a centric motion. While what is occlusion? So when the motor moves the TMJ joint, what comes into contact are the teeth, and these are called this is called as occlusion. So we need to understand that our body is made up of certain elements and a biomechanical system within which the functionality of our face or head neck face occurs. So it is very much inacceptable to understand that any form of change in the teeth, we try to repair it, we try to move it, or we try to remove it, will directly or indirectly cause an effect on the occlusion of your teeth. And this is something which is dreaded in dentistry. So we all deal with one science, and that is occlusion. Whenever we give a crown or we do a surgery, even we extract a tooth, what happens is if we do not give a teeth over there for a long time, the forces of the nature, the forces of the physics take over. So either we have mesialization or distalization of tilting of the adjacent teeth. Why does this occur? Because this is the bodily movement of the teeth to come into a proper occlusion and help the body to bite. So we all know that there is something called as centric occlusion or a centric bite. But what does this centric mean? It is an adjective and it should qualify a noun. So what does occlusion means? It's a noun. So what kind of occlusion does a centric is? So centric is not an occlusion at all. It is a relation that has nothing to do with the teeth, because it is only a centric, that is reproducible with or without teeth. We go back to our textbook prosthodontics final year days, we know we always read that definition of centric relation. And right now, what I'm telling is centric relation has nothing to do with occlusion. It is just a relation which is reproducible with or without teeth. So, centric relation is a jaw relationship. It describes a conceptual relationship between the maxilla and the mandible. So, centric relation has been described in three different ways: anatomical, conceptual, and geometry. I don't want to go into those definitions, as we all know these definitions by heart, and we have been doing this day in, day out in our clinical practice as we are doing crown and bridge and implant dentistry. So, how do we analyze occlusion? Having stated that occlusion simply means contact between the upper and lower teeth, the concept can further redefine or by define those contacts as it is closed or stationary, as the static occlusion when there is no movement, or when it is moving, that is your protrusive, your lateral protrusive, or your mediotrusive movement, that is the lateral movements, is called as a dynamic occlusion. Next comes is the mandibular movement. Why it is important to record the mandibular movement in occlusion? Because we eat food and that is not stationary, that is not static. It is a dynamic movement where all the three masticatory or biomechanical functional loads takes place. So your jaw moves, so your TMJ is in function, your muscles of mastication are in function. That's when your teeth meet. So we need to always trace the mandibular movements. So what are the mandibular movements? We have protrusive mandibular movements, that is when our condyles move the jaw anteriorly or in front. What are working and non-working movements? So when we move our jaw to our right or to our left, the compartment of your TMJ is one side is working and one side is non-working. We always confuse, and when we move our jaw to right, we feel that the left side of the mandible is moving and it is a working side. No. When you move your jaw to the right, that means your right mandible, right condyle is getting your jaw to move on the right side and your working side happens to be right. While we move our jaw to the left happens to be the working side, because the condyle from the other side is coming out, while the condyle from the working side is pulling the condyle from the left to the right. So these movements we need to record when we go towards building a perfect harmonious occlusion in the patient's mouth. What are guidances? What is the posterior guidance? What is the anterior guidance? We always feel that the guidance is something which is always, we get it with the teeth. Anterior guidance means anterior teeth, posterior guidance means posterior teeth. No. Anterior guidance and the posterior guidance is always derived by TMJ or the condyles, while the anterior guidance is the teeth in front of the condyle. So your last molar can also give an anterior guidance. It is not that the anterior guidance means the anterior teeth. So I'm just reading out the definition. The posterior guidance system of the mandible is provided by the temporomandibular joint. As the head of the condyle moves downwards and forwards, the mandible is moving along the guidance of the pathway, which is determined by the interarticular disc, that is in the TMJ. And this is enclosed in the joint capsule. So this is posterior guidance. The movement of the mandible along the slopes of your TMJ is the posterior guidance, while the anterior guidance or the lateral movements in the mandible. So this can be anterior to the TMJ. So which teeth are these? It can be third molar, it can be second molar, it can be loop. So when we say that we have anterior teeth missing, so the patient does not have anterior guidance, it's a misconception or a misnomer. Patient does have an anterior guidance, because the anterior guidance is the teeth present in front of the condyle. So this can be third molar to the central incisor. No matter how far back these teeth are, they still are anterior to the temporomandibular joints. So a patient can, with a severe open bite, always has an anterior guidance. So always see to it that we always had this misnomers or always had this question mark when it comes to anterior guidance and posterior guidance. And most of the time while communicating to the lab persons also do not know. They say, so we do not have an anterior guidance, please record the bite again. Because there are no anterior teeth, please record the bite again. No, there is an anterior guidance. There is a posterior guidance. TMJ is the posterior guidance. Teeth is the anterior guidance. So now, when we come to what are different type of occlusion which we can see in a natural dentition or which we can reproduce in the patient's mouth. So this is called as mutually protected occlusion. Then we have anterior protected, canine guided, and group function. These are various occlusal schemes which are there in the patient's mouth. As we move ahead, you can see it in the pictures as well. So the best suited occlusion format for a patient is either a group function occlusion or a mutually protected occlusion. So what do I mean by a mutually protected occlusion? So when your posterior teeth come in occlusion, your anterior teeth are in disocclusion. What do I mean by disocclusion? They do not touch or at a very slight occlusion. So this is something called as a mutually protected occlusion. And when you do a lateral movement, so when you do a protrusion, your anterior teeth come in contact while the posterior teeth are in disocclusion. So this is called as mutually protected occlusion, where a group of teeth protect the other teeth when they come in contact. From what kind of forces? These can be lateral forces. This can be any kind of forces apart from centric. Again, what is a canine guided occlusion, which we rarely see in any of the patients? And when we are doing a full mouth case, maybe completely with a natural dentition, we do not give this kind of occlusion unless patient has a natural canine guided occlusion. So canine guided occlusion is when your canines come into contact in the lateral movements, all your teeth are in disocclusion. So do you think canine guided occlusion is a better occlusion when it comes to implants? No, it is not, because canines take the maximum lateral forces when they come in contact, and implant lateral forces is something which is like a villain. So as I told you, in a mutually protected occlusion, the most preferred scheme, and it does the best job of dispersing the occlusal forces of both vertical and horizontal in nature. The teeth best suited to the dealing with them, and not everyone has this type of occlusion. The anterior teeth protect the posterior teeth in eccentric contact, while the posterior teeth protect the anterior teeth in MI. MI means maximum intercuspal position. Often the cuspids are the only teeth contacting in the lateral movement, and the incisor teeth are contacting in protrusive movement. So this is one of the best suited articulation or occlusion in the patient's mouth. This is where you can see when the patient is in a maximum intercuspal position, the anterior teeth are in minimal or no contact. When the patient moves in the protrusion, your anterior teeth are in contact while your posterior teeth are disoccluded or they are not in contact. So in this type, vertical horizontal overlap of the canine teeth disengage the posterior teeth. So this is called as canine guided. Can you see a canine in the image? The canines are touching, the cusp of the canines are touching each other. So what happens is when the cusp of the canine touch each other, all other teeth are in disocclusion. So this handles the lateral forces well when it comes to natural dentition, because canines being the cornerstone of the mouth, with a good bone geometry around them, they can take the lateral forces well. But in implants, do not dare to give a canine guided occlusion, because lateral forces are villain when it comes to your implant occlusion. The scheme is defined when the multiple teeth come in contact. So this is called as group function. So now we understood from centric to protrusive. Now we should understand in the lateral movements. What happens in the lateral movements is when your multiple teeth come in contact on the working side while the other teeth are disoccluded, it is called as group function. Again, this teeth avoid maximum lateral forces on the teeth. So it is called as group function. So a group of teeth coming in contact, while the other side of the teeth are in disocclusion, is called as a group function occlusion. Now we understood what are the different kinds of occlusion. I'll revisit again. So our teeth are, we have three things in our mouth which are important: the teeth, the periodontium, and the articulatory system, that is the TMJ. Then we spoke about the different movements, that is your lateral movements, your centric relation. Then we spoke about different occlusal schemes, that is the canine guided, the group function, and the mutually protected occlusion. This becomes the crux of your occlusion when it comes to implants, as well as when it comes to your natural dentition. So, what is different when it comes to implant occlusion? So, what is different in implants? We do not have periodontal ligaments across or along the implants, while in the teeth we have periodontal ligaments. So, will our implants take those insults of the occlusion if not designed properly? Not at all. What will happen if the implant occlusion is not designed or architect properly? There will be loss of bone. One, moving ahead, we might have a screw loosening, we might have a fracture in the screw, and even we can lose an implant. So it's always dreaded, in dentistry, a failure of a root canal cannot be taken as a taboo. We can do a re-root canal, but implant failure is always a taboo. Whenever a patient comes to us, they always ask, what is the warranty or how many years this implant will work? And the answer is completely lies on implant occlusion, because it is a key towards your long term implant prognosis. So, what is it different? So, in implants, we should always direct the forces along the long axis of the implants and not along the lateral axis. When I mean the lateral axis is the forces are along the implant straight. If we have the lateral forces, the forces will directly go and engage in the crest of the bone, and that's where your bone loss will happen. So, see to it that whenever you have implants versus tooth or implants versus implants, your forces should be along the long axis. How do we get these forces along the long axis? Always try and give a cusp and fossa relationship. Do not go for those flat tabletop crowns which are having like a long table, like a dining table, because these crowns are detrimental towards providing lateral forces to your implant crowns because they do not have a stop. Have you seen the cows and buffaloes having food? They ruminate like this. What happens when the cows and buffaloes ruminate? Because they have flat table like teeth. These teeth provide lateral forces to your bone. When we design our implant occlusion, see to it that when you write it on the paper, I require a full anatomic crown with defined cusp and fossa, which will give me a 3-point contact. Do not write, you just send a crown. It's so I always kind of read and go for a lot of lectures, and there was one lecturer who always told me, so whenever I write a note to a lab, I write it in a form of an essay. What I exactly want, what kind of prosthesis I want, what kind of occlusion I want, what kind of prosthetic material I want, everything he writes in form of an essay. And we should always, instead of having a commercial lab book, we should always have a clinic book where we mention all the lab things. It is always better to communicate with the lab. Also have maybe a WhatsApp group. So it's very common in India to have a WhatsApp. So have a WhatsApp group with your lab technician to understand and design the prosthesis the way we want. Now moving ahead, what should be the occlusal scheme? In implants, you should always go for a mutually protected occlusion or a group function occlusion. Why? Because these are the most safest occlusal schemes which are available to reduce the lateral forces in the patient's mouth and on the implant crown. And last but not the least, what we should also see is the implant movement. Do our implant move? Yes. Do they move as our teeth move? No. Implant movement is hardly 2 to 5 microns, whereas a tooth movement is somewhere around 28 microns. Because the teeth are provided with a periodontal sac and the implant is directly in contact with the bone. So always see to it that whenever we design our occlusion, we should take into consideration our implant movements. So what is my aim towards occlusion in the osseointegrated prosthesis? Direct the forces along the long axis of the implant, minimize the lateral forces, place the lateral forces as anterior to as possible, and when it is impossible to minimize or move the lateral forces anteriorly, distribute them over as many teeth as possible. That is called as group function or mutually protected occlusion. In concept of occlusion suitable for implant supported prosthesis is basically the same as that of methodological occlusion. Centric relation remains the same. What changes? So when an implant crown or occlusion comes into bite, see to it that you have slightly open bite. Open means I do not want an open bite where a whole peanut can go in between the implant and the adjacent occluding prosthesis. It is better to have a slightly open bite. So what happens is when the patient overloads or when he eats the food, your implant prosthesis can come into occlusion. Now, when all other teeth come down, when the patients bite in the pressure in the periodontal sac, that's the time your implants should come in contact. Because implants do not or move very minor when compared to the teeth because of the periodontal ligaments. So in centric contact, osseointegral crown should not contact with the opposing teeth under soft bite pressure, while the occlusal rod or in overload it should contact. So under strong bite pressure, the osseointegrated supported processes should contact. That is when the tooth intrude approximately 28 to 30 microns, your osseointegrated prosthesis should come in contact. Again, to avoid the lateral forces, see to it that you give a Cuspment fossa or a tripodal contact for your implant crowns. And during eccentric movements, we need to have as many teeth in contact or we should have them in disocclusion on the working and the non-working side. That is why your implant occlusion should be categorized as static and dynamic, and always see to it that dynamic implant occlusion plays a very important role in our implant occlusion. So this is something which I wanted to show. If you see on the image, the straight arrows marks the axial forces, and this is only achievable when we have a tripodal contacts or when we have a cusp to fossa relationship. Also see to it that the cusp and fossa are not very sharp, but make the cusp and fossa shallow, but it should have a 3-point contact. So anterior segment of the osseointegral processes guide the posterior segments. Similarly, you should not give a canine guided occlusion. It is not recommended in that area because maximum forces on the canine are lateral forces and we might lose a fixture or there might be chances of bone loss. So whenever we have a canine guided occlusion, see to it that you shallow the cusp of the canine and make it into a group function occlusion. So now coming to individual cases from FP1 to RP4. So fixed prosthesis with a natural opposing teeth, that is FP1 to RP4, implant restoration should follow mutually protected occlusion. In protrusion, there should be total absence of the posterior contacts, especially in the cantilevered prosthesis units. The masticatory forces generated during the lateral excursion is decreased in absence of posterior contacts. This assists in reducing the noxious effect of the lateral forces. 2 or more implants should always take the lateral forces. So it is always better to have joint crowns. Also, you should always have the teeth in in a group function occlusion, so they can take the lateral forces better. If you have a canine guided occlusion, please add canine and the premolars behind it to come into a group function so they can take lateral forces better. Minimal occlusal contacts in the cantilevered region. A lot of science is engineered or over-engineered towards all on 4 or all on X, where we have certain units of our implant crowns which are cantilevered. Because of all on 4, we tilt the implant so we get the maximum AP spread. But at the same time, the teeth behind the molars or the second molar or maybe sometimes premolar are in a cantilever segment. So nonetheless, we give it in a complete occlusion for the patient, but see to it that this cantilever teeth should have minimal occlusion and not a complete bite. Also see to it that when we are doing a full arch case in a maxilla or a mandible, more the implants, it is always better than less number of implants and more number of teeth. So 7 to 8 implants should support a complete implant prosthesis in 2 separate units suggested in mandible, while it should be in 1 full unit when it comes to maxilla. You can see in the OPG format over here that in mandible we have 2 separate units and we give joint prosthesis, while in maxilla we can give it in 1 full joint prosthesis. The occlusal scheme is completely dependent on the skeletal relation, the implant distribution, the occlusal vertical dimension, posterior support, your interarch distance, crown to implant ratio, segmental inclination, aesthetic occlusal plane, orientation, tooth exposure, and lip support. All these things we do when we are doing a jaw relation, that is when we are recording a centric relation or when you are recording a vertical dimension. All these things we have to take into consideration while designing implant occlusion. Also, why vertical dimension is very important when it comes to occlusion. It helps us in deciding the kind of prosthesis which we have. Longer the vertical dimensions, maybe more than 18 millimeters, it is always better to give removable prosthesis. If we have somewhere around 15 to 18, it is always better to give hybrid prosthesis. So depending on our implant vertical dimension, we have to decide our type of implant prosthesis which we need to give to our patients. So coming towards individual case, so we all know Kennedy's classification. Back in our dental school days, we used to read that. So what happens when we give implants in mandibular oval or a fixed denture? So it is recommended to have a mutually protected occlusion because patient is edentulous upper and lower. Whatever occlusion, we are going to develop it. Whatever it is, we are going to design the occlusion. So it is always better to design a mutually protected occlusion when we are going for a maxillary and mandibular fixed bridge or a hybrid prosthesis for the patient. So we always see to it that there is a 30 microns clearance in the anterior region. So you can use a 30 microns paper and see that there is a 30 micron clearance when the posterior teeth are in maximum intercuspation. There is this occlusion which should be employed when the patient is in the eccentric movements. And also on the lateral movements, it is always customary to have a group function occlusion, so to reduce the over stresses. Next comes is a situation when we have a Kennedy's class 1, that is bilateral implants missing. So how do we develop occlusion? We do have an anterior guidance and the posterior guidance. The anterior guidance is from the available premolars, while the posterior guidance is from the TMJ. So just revising what we did in the when we were discussing the natural occlusion. So clearance in the anterior teeth should be smaller than the natural teeth. So how do we get this clearance? By shallowing the cusp and fossa. Recommended disc occlusion is always 0.1 mm to 1.5 mm on the protrusive and the non-working side and on the working side. The occlusion should always be mutually protected occlusion or group function occlusion again when we develop in such kind of cases. Now moving to Kennedy's class 2. In this, we do have anterior and posterior guidance, but occlusion is derived from the rest of the available teeth. So what we should see is that the osseointegrated bridge should always come in contact when the patient is under heavy biting forces, while they should be in no contact under the light biting forces. We can see to it that these bridge can be cemented or which can be made together, so it can be splinted, so all the lateral forces can be dissipated. Next comes is Kennedy's class 3, when we have anterior and posterior segment of the teeth available and we have one or two teeth missing in the patient's mouth. So vertical dimension is available from the patient's own jaw. We have centric relation, which is again patient's gives us a centric relation. So what we need to see is developing a occlusion, which is group function when your implant segments come in eccentric movement in a group function occlusion. They should come in contact together to again reduce the lateral forces. So what is important in implant occlusion is to reduce the amount of lateral forces on the implant fixtures, which reduces the bone loss. So the weak link in a tooth is a periodontal disease which is bacteria linked, while weak link in an implant, which is peri-implantitis, is completely linked on the forces and not on the bacteria. So peri-implantitis, mechanical failure or biomechanical failure happens because of your implant occlusion and not because of some bacterial infection. Then comes is Kennedy's class 4, when we have missing anterior teeth. So definitely we need to go for group function occlusion. That is when your posterior teeth come into contact, your anterior teeth are in minimal to no contact. Then we should always see to it that these teeth are again splinted together so they can take the maximum lateral forces when it comes into the patient's mouth. Next is overdentures. So in overdentures, the entire theory of your implant occlusion changes what we have discussed for the fixed. So back in our school days, we used to learn about dentures, balanced occlusion. It is bilateral harmonious contact between the upper and lower teeth when the teeth come in contact. So this is something which we need to go when we are discussing about removable dentures. We should have balanced occlusion. So when in maximum intercuspal position, in lateral motion, in protrusion, all your upper and lower teeth should come in contact. And this is only achievable when we record centric relation in the most dynamic way. When we put up the case on a semi-adjustable articulator and not on a 3-point or a mean value articulator, when we can simulate all the movements. And this is something which is very important, that all the teeth should come in contact, whether it is centric, whether it is eccentric movements, to reduce the maximum amount of lateral forces. So in removable dentures, the lateral forces are at their peak because the patient does not have any kind of proprioception, unlike the other Kennedy's class 1 to class 4, where the patient have teeth. So we should see to it that to reduce the lateral forces, all the teeth should come in contact in centric as well as eccentric movement. Also, this reduces the tipping of the overdenture, which is also called as the Christensen's phenomenon. When the patient comes in the protrusion, the upper or lower dentures uplift from the posterior. To avoid that, all the teeth should come in contact. So this is called as Christensen's phenomena, which we should reduce it. So revising the occlusal guidelines, this is through MISH. So in a full arch fixed processes, there should be bilateral balanced occlusion with the opposing complete denture. A group function occlusion or a mutually protected occlusion should be always given. No working and balancing contacts on the cantilever prosthesis. Reduce the cantilever as possible. Infra-occlusion up to 100 microns in cantilever prosthesis. And freedom in centric, that is, we get it through shallowing of the cusp and the fossa. In overdentures, it is always bilateral balanced occlusion or lingual occlusion, where we can have all the teeth meeting each other in centric as well as eccentric motion, while in monoplane occlusion, severely resorbed ridge cases. Processes for fixed anterior guidance should always be through the natural dentition. As we discussed, anterior guidance is available through the available dentition. Group function should always be the priority when you're designing a occlusion for the patient. Center the contacts, narrow the occlusal table, so your implant teeth should be narrower than the rest of the teeth. If patient has a crossbite, always go for a crossbite. Do not try and change the crossbite because that is in the patient's mouth. Single implant cases, anterior and lateral guidance is in accordance with the natural teeth. Light contact on heavy bite and no contact on light bite. And center contact with flat cusp and fossa and no offsets, which is there. So what is important in implant occlusion? We need to increase the support area. And how do we increase the support area? That is the quality of the bone. So we should always go for extended healing time, progressive loading. So do not load the implant full mouth. Always try and give temporaries first. Understand how the patient's biting is, and then go ahead and go for final processes. How do we understand the bone quantity? So depending on the bone quantity, we can decide the number of implants, the diameter of the implant, the length of the implant, and the implant surface. Now, next is how do we improve the force and direction? It's with respect to the occlusal morphology. So, what do? We can flat the central fossa or shallow the central fossa, reduce the cuspal inclination, reduce the occlusal table, and guide the forces along the long axis of the tooth or center contacts. Reducing or magnification. So how do we do that? Occlusal contacts. We need to position and distribute the occlusal contacts on as many teeth as possible. Type of processes, we need to reduce the cantilever. If the crossbite is there, we can give a crossbite. We need to splint as many implants as possible, and always remember the key implant position. So key implant position is according to the shape of the arch when it comes to your full mouth cases, whether it is square, tapered, ovoid. Then the key implant position according to Mish is the canine and the molars. So we need to understand these are the key implant positions where we need to place the implants to reduce the forces. Thank you very much. Any questions?
Thank you, Doctor, for such an insightful webinar session. And yes, moving towards the Q&A time. Q&A, yes.
Yes.
Yeah, the first question is when the lab sent the finished prosthesis, how do we see whether it is mutually protected or not?
So, as I mentioned, whenever we are going for our implant prosthesis, see to it that we do it on a semi-adjustable articulator where we can simulate the movements. Or if we are not using a semi-adjustable articulator, just place the crown, do not cement it in the patient mouth, and ask the patient to do the lateral movements as well as the protrusive movements. So then we can see when the implant crown is coming in contact or not. But if it is a full mouth case or if it is including upper and lower multiple teeth, it is always advisable to put the case on a articulator by recording a phase because it gives the maximum simulation as the job.
Yeah, okay. Next is why implant crown can be given as a single unit in maxilla but has to be splitted in mandible.
Understood. So the bone morphology or the quality of the bone in maxilla is always D3 or D4. So it is a softer bone. So if it's a simple example, if I give you a one pencil and ask you to break, you can break it into two pieces easily. But if I give you 10 pencils and ask you to break, you cannot break it. Similarly, in a softer bone, if you splint all the implants, the lateral forces and the functionality is together. So again, in mandible, why we need to splint? So going back to our embryology, first year BDS days, what happens is your mandible is a union of two bones, where we have a mid-symphysis raphe over here. So whenever the forces happen on the mandible, they try to open up. So it is always better to split the mandible in the anterior region to reduce the lateral forces.
Okay. The next question is why not mean value and Hanau in overdenture cases?
Why not
Mean
mean
value
value?
and
You can use Hanau articulator. Hanau articulator simulates all the movements. Mean value articulator is also called as a 3-point articulator, so it does not simulate movements. And in a full mouth complete denture case, as I told, the scheme of occlusion is called as balanced occlusion, where there is your balanced occlusion is when your teeth should come in contact in centric as well as eccentric movements, and this can only be simulated when you do the teeth arrangement on a Hanav or any kind of semi-adjustable articulator and simulate all the movements.
Yes. The next question is, what should be the thickness of the articulating paper for implant occlusion?
28 microns, 20 to 30 microns. That is when you bite, the tooth moves around 20 to 28 microns. So your paper should be that thick.
Okay. The next one is how advisable to use shim stock?
Shim stock, again, in biting, shim stock will just give you the, you can see the silver foil which gives you the recordings over there. So what happens is you can use it, but only for, you can say, reduction of the high points. But you should always have shim stocks just to mark the overloading points over. You mean the shim stock is the silver foil paper which we, right?
Yeah. Okay. The next question is, hello sir, while replacing canine in upper or lower jaw with implant, how to use articulating papers for giving occlusions?
So more than articulating paper, you need to use articulator when you are restoring a canine. So what happens is when you do a lateral movement, your canine and the teeth behind it should all come in contact as a group function of occlusion. So instead of articulating paper, and if you are using the articulating paper, see to it that you can use the articulating paper at the lab side to reduce the cusp, the sharp cusp of the canine. That is the thing. So you need to use articulating paper just to reduce the sharp cusp and not just get the canine, the premolars, and the first and the second premolar all in contact on the working side when it comes towards your group function occlusion to reduce the lateral forces. So your lab technician should use articulating paper so that the canine, you can reduce the shallow the cusp, the sharp cusp of the canine, and get all the teeth in contact as a group function.
Okay. Yeah. Next question is, temporary prosthesis is an occlusion after immediate implant in anterior region or out of occlusion?
So again, in anterior region, the temporary prosthesis, in an immediate implant where we go for immediate loading, see to it that your prosthesis, as I told you, mutually protected. So it is at minimal or no occlusion. It is called a mutually protected. So when your posterior teeth come in contact, your anterior teeth are in minimal or no occlusion.
Doctor, next question is, a minimum amount of infra-occlusion will be better for an implant crown?
Yes, as mentioned, the periodontal movement of the teeth is 28 to 30 microns, while the implant is 5 to, you can say, 5, maximum 5 to 7 microns. So very minimal amount of infraocclusion should be there, not like a whole peanut can go in or something. So this can be developed with your lab technician having the same kind of articulating paper what you have it in the clinic. Usually what they do is they use the coping paper or the blue paper which is available at the Xerox shop. So that's why you don't get the occlusion what you get it in the patient's mouth and in the lab.
Yes. Yeah. The next question is, which articulating paper is used to check occlusion?
Which articulating paper? Bosch.
Okay, the next question is, can we use a Fox plane for proper occlusion in full mouth implant?
Yes, Fox plane is when you have to get Fox plane is where you do a jaw relation, and when you need to do orientation jaw relation, you need to have the horizontal and the vertical plane. That time you are using a Fox plane, and moving ahead, you have to do a Facebook transfer. So it is a part of when you do a full mouth implant. Fox plane will analyze your plane, the horizontal plane.
Okay.
So in the
The
jaw
next,
relation, when it comes to jaw rims, wax rims, you always have to use a Fox plane.
yes. Next question is, all 3GR do incomplete mouth implant rehabilitation?
Yes, of course. Whatever we do in general dentistry, the
Yeah.
rules are same in implant dentistry. Only thing what we need to understand is that we need to reduce the lateral forces and we need to give the axial forces. And the cusp and fossa should be there, complete anatomical, but the cuspal and cuspal should be shallow, not flat.
Okay. The next question is there any occlusion variation in angled abutment and straight abutment?
Occlusal relation in angled and straight abutment remains the same. Only thing is, if at all you are giving a all on four, where you tilt your implants and then you angulate, make the implants using a multi-unit abutment and straight, and then you have a cantilevered segment, then of course the cantilever portion should be under inflow occlusion. But if you have a single implant and you have placed it, you may be a bit angled and then you use it to make it straight, definitely there will be, lateral forces will be higher on that kind of implants.
Okay. The next question is, suppose one patient had gone for therapeutic extraction for the orthodontic treatment or long-standing edentulous state, and space of implant placement is around 5 millimeter. In that case, what kind of occlusion should be given, as no proper occlusion is there because of long-standing edentulous state?
So patient is completely edentulous or partially edentulous, and the 5 millimeter implant is a short implant or 5 millimeter is a diameter. What is it? Can you just frame the question properly? Because patient has gone for orthodontic extraction, so
Yeah,
definitely the orthodontist must have closed the space.
I think doctor, the that person is asking that suppose like if he that patient has gone for orthodontic treatment for the some, and he has gone for under like therapeutic extraction, or for
Yeah.
example any long standing edentulous state. So in that
Yes.
case, the
Yes.
space the space of
Hmm.
implant placement is around 5 millimeter. So in that
Hmm.
case, what kind of occlusion should be given?
The occlusal consideration remains the same. Even in long or a short implant, the occlusal consideration remains the same. You
Okay.
need, if at all you have a 5 diameter length implant, see to it that you have a larger diameter of your larger diameter implant. So implant comes in diameter and length. So if at all the length is shorter, diameter should be wider. You cannot have a 3 by 5 implant. You should always have a 4.5 or a 5 diameter implant with a 5 or 6 height. So as I told you, the implant design also takes a lot of importance. Wider the diameter, the forces can be concentrated more. If a smaller the diameter and plus the smaller the length of the implant, definitely the forces will be higher on those prostheses. In that situation, you should have two implants in place and then give prostheses. Or if a single crown is there, a single missing tooth is there, then you see to it that you have a wider diameter implant with a shorter height. Then it's fine. Because
Okay.
a lot of hue and cry has been done nowadays with short implants which are available, but occlusal considerations remain the same.
Okay. The another question is, which is better to oppose implant crown, either PFM or zirconia?
Uh, Both are better depending on the patient's like, of course. But if you ask me, I'll always go for a softer material. So you can definitely decide for zirconia as well. But again, your forces should be on the along the long distance.
Okay. The next question is, how much gap required between teeth and implant supported prosthesis for good bite registration?
How much gap required? We should have a proper centric bite with maximum intercuspal position. When you when you make a bite, right? The
Yeah, yeah.
question is when you make a bite, it should be in a alu wax with a maximum intercuspal position, even
O-
for the implants. But when you're
Okay.
developing or when you're designing an implant crown, either on a CAD CAM or either on a castable, you should use the articulating paper so you can get that 28 microns of the 5-10 microns when the complete occlusion happens, the infra occlusion, what is recommended.
Okay, okay. Okay, yes. The next question is, for fresh candidates or beginners, sir, what are your suggestions for learning implantology if we are not going to do PG in process?
So implantology again is a long science, and what happens is do not start doing full mouth cases or dentures. Always go towards doing single implant cases first. Always choose a mentor. It is always better to choose a mentor and then go ahead and, even when I learned the implants, someone was there to handhold me. And then we started doing implants. So always choose a mentor who is there who's there to help you as a mentor, who will help you place the implants. And as the start of my lecture, as I said, planning of the implant plays a very important role. You need to plan a case. So if you have a 4-6 missing or maybe a 1-1 missing, it is the planning which plays an important role. How you gonna place the implant over there? What is the bone type? What is the bone condition? Rather than I just not need to place the implant and give a crown. So planning plays a very important role in that.
Very true. Okay, the next question is, if we checked the prosthesis in mouth for mutually protected occlusion, but it is not in mutual protected, what are the ways to correct, or we can grind the prosthesis to get it corrected?
Yeah. So what I suggest is do not grind the prosthesis in the patient's mouth. If they are not in mutually protected occlusion, they can either be in group function occlusion because there is some kind of occlusion. So we always do a series of trials before we directly give a crown to the patient's mouth. So at this trial stage, we will come to know what kind of occlusion the patient has. And then we can inform the lab accordingly that, okay, I need these teeth in contact. I do not want these teeth in contact. So this is where the lab person will grind you and send it to you.
Yes. The next one is there any change in occlusion with cement retained or screw retained
No,
prosthesis?
no change at all.
Okay. The next one is, hello sir, how we do jaw relation in all-on 4 or all-on 6 implant?
So the steps of jaw relation remain the same. So you have placed the implants, you make the impression, you ask the lab to send you a proper jaw relation with the wax rims. So you place the wax rims in the patient's mouth. So in implant, what happens is the wax rim comes in dual format. So you can screw in those wax rim in the patient's mouth so they become as fixed and stable in the patient's jaw. Then you ask the patient to do, then you record the vertical dimension, then you record the centric relation, then you record the orientation jaw relation. That is, you go ahead and make a face bow. Then you send this to the lab. So it is the steps remain the same as the normal denture patients. Only thing what changes is it is in the implant processes. So see to it then when you ask for the jaw rings, they should be static in the patient's mouth. That means we can lock them using a screw.
Okay. The next one is, can you show pictures of getting a perfect occlusion?
There were back behind. Good. So you can see over here, this is a perfect occlusion. This is a perfectly mutually protected occlusion where anterior teeth are in no or minimal contact while the posterior teeth are in complete contact. When the patient moves in protrusion, your posterior teeth are in disocclusion while your anterior teeth up to canines are in group function or in contact. So this is the ideal occlusion what we is recommended in the patient's mouth. This is in group function. The group of teeth are in contact. So this is something which is ideal occlusion what we develop in normal full arch cases as well as sorry for that, as well as in your normal dental implant occlusion.
Okay. The next question is, which company implant preferred option?
There are many companies as far as so again Quickdent is a very good implant where it is economical as well as they have a range of implants. So they can definitely, if you're a starter, always try to start with an implant company which is easily available with all the components. You can
Yes.
even go for any there. Since there is implant occlusion or implantology is not a brand specific. The science remains the same for all the implants. It's like that.
Okay. The next question is, few patients report with loosening of implant crown after few years of placement. What would be the possible cause, and does the minimal occlusal discrepancy during the time of fixed prosthesis delivery would be the reason?
Yes. So what happens is screw loosening can happen because of occlusal overload. Also, it is a kind of mechanical failure because what happens is when you torque the screw at certain torque, maybe 15 or 20 microns, and after certain years the screw loosening happens, that means there is some kind of overload on the implant and you need to revisit the occlusion. So what I suggest is ask the patient to, first day when you torque the crown in the patient's mouth with the implant, you torque it and you send the patient home, call him after 48 hours, see to it that you retorque the implant. That is the time you will come to know what is the exact occlusal overload. The patient, whenever there is an occlusal overload, either there will be a screw loosening or a screw fracture or the fracture at the implant's neck.
Okay, the next one is, sir, in full arch cases, if we do denture conversion, then what point to remember whole maintaining occlusion?
In full arch cases, when you do a denture conversion, as I told you, the planning is when you do a full arch case in upper lower edentulous jaw, denture is the first starting point of the patient. So you need to fabricate the denture first and then place the implants. So when you fabricate this denture, see to it that this denture is in balanced occlusion and the same denture is been loaded in the patient's mouth. Because this denture will be a standpoint towards your provisional or temporary denture, as well as towards your standpoint when you are giving permanent prosthesis for maybe fixed or removable. So this denture will be like which will have a set of centric as well as vertical relation, which is pre-recorded. So whenever you're doing a denture conversion, the denture is the first starting point of before you're placing the implants.
Okay, the next question is, if canine is decayed, replaced by implant in 19 to 27 years of age group, so can I perform orthodontic treatment above the implant?
No, you cannot bond the brackets on the implant because again there will be movement, right? You cannot move an implant, so you know it's not. Other all teeth, yes, you can do ortho movements, but not on the implant. And it is always advisable to first finish your ortho treatment and then go ahead and place an implant.
Okay.
It should be reversed. Finish the ortho treatment first and then go ahead and place the implant.
Okay. Doctor, next question is, material of choice for implant crown.
Material choice for
Material of choice for implant crown.
material of choice for implant crown, again dependent on what situation it is. If it is a full arch case, I will always go for giving softer prosthesis, maybe bio HPP or you can say hybrid dentures or something like that. But if it is an individual crown, it depends on zirconia or PFM. It's completely fine, unless the forces are directed in the proper way.
Okay. The next question is, bezel or conventional implant, which one is best for anteriors?
Basal or conventional, which one is
Best for anteriors.
conventional? Basal implants are only placed when you do not have bone or when there is atrophic bone. It is always better to go with conventional implants. Basal implants are treatment of choice for atrophic ridges and not for single missing teeth or something like that. Always go for conventional.
Okay. The next question is, most common reason for implant failure is?
Most common reason for implant failure is occlusion.
Okay. The next question is, sorry
And
for
of
asking.
course, surgical placement also. I mean, you need to plan your surgery where you're going to key positions, the shape of arch, everything is important. But the crux is the tip of the Everest is occlusion. Because
Okay.
end of giving patient to eat food, for that you need to
Yes.
place implants in a proper way. So I can say surgical as well as mechanical implant.
Next question is,
Yeah.
sorry for asking this, RP4 and RP5, in which cases D3 and D4 bone? I think,
RP4, RP5,
yeah, in
D3,
which
D4 both,
cases?
right?
Yeah.
So RP4 and RP5, the main difference is RP5 is in cases where you are giving a removable denture, while in RP4 it is implant retained, so it can be either fixed or removable. So RP5 is in completely atrophic ridges where your vertical dimension is more than 18 millimeters. It is always better to give removable prosthesis. While RP4 is where you have a 15 to maybe 15 millimeters of vertical dimension. You can, like in most of the all on four cases or tilted implants, you can definitely go for RP4. So it completely depends on the availability of the space, the vertical dimension. So depending on that, if it is a completely atrophic ridge with a very higher amount of vertical dimension, then it is always better to go for RP5 because your vertical forces also play a very important role in your prosthesis failure.
Yeah.
More bigger the prosthesis, the forces are more. So it is always better to give removal in a highly atrophic ridges. Well, RP4 is completely fine when it is implant retained. So it is more or like fixed prosthesis or fixed removal prosthesis. So anything below 18 millimeters is better.
Okay. The next question is, sir, is immediate loaded implant is a real risk factor of failure? Why docs do especially on multiple replacements?
Immediate implant placement is never a reason for implant failure if it is done properly. Immediate implant placement has its own science. So when do we do immediate implant? It is always the implants which are tilted, or when we use the implants with a larger diameter and a larger length. At this particular position, we can load the implant. So it depends on the kind of torque you get, the amount of implants you are placing, the number of implants you are placing, the number of implants you are splinting. Are you tilting those implants? So there are a lot of factors in immediate implants. So there is no risk in failures of immediate implants, but this science needs a lot of acumen or study before you even place the implants. And it's always better to load the immediate implants with a softer occlusion, with a softer prosthetic material. So you can convert your dentures into immediate loading, and then moving ahead, you can give you can say the final prosthesis in the desired material what the patient and you want.
Okay. Okay, guys, I will be taking this last 7 questions. After that, I would like to request no further questions because we are running late. So I'm taking the first question is smokers, how to prevent screw loosening? Like how to prevent screw loosening in smokers? Can you suggest?
There is no documented study of smokers and screw loosening. Screw loosening will happen only if you don't torque the crown or because of occlusal overload. In smokers, there is no documented screw loosening study I have overcome. That is the thing.
Okay.
Smokers, of course, implant failures do happen, but again, it depends on the amount of smoking you do.
Mm. And okay, the next question is, sir, what is FP1 and RP4 criteria? Is it for implant placement?
FP1 to RP4 criteria is starting is FP1 is fixed prosthesis and RP is removable prosthesis. It completely depends from the planning what your patient wants, what are the economical implications, what are the anatomical implications, up to designing of the occlusion, everything. So yes, it is a nutshell like FP1, FP2, FP3 is called as fixed prosthesis. It completely depends on your vertical dimension. And RP4 and RP5 is removable prosthesis, which depends on atrophy of the ridges.
Okay, the next question is software. Kindly suggest for implant placement planning. Any software?
Blue Sky Bio. Blue Sky is there. Then a lot of your CBCTs, it has inbuilt software in it. So you can definitely plan implants on there.
Yeah.
And
Okay,
you
the
can
next one
implant
is
proper implant prosthesis, it's ExoCAD. To plan your
okay.
implant prosthesis, it is ExoCAD.
Okay. The next question is, sir, in full arch cases, how to decide how much crestotomy is to be done and how to decide length of implant in such cases?
So length of implant is completely depends on your CBCT. Crestotomy is only done when you have a crestal ridge. Crestotomy is not required in all the cases. Only if you have a narrow ridge, it is better to do a crestotomy. It has nothing to do with implant occlusion or vertical dimension. So it's completely fine. And how to decide on the implant? It is on the CBCT. When you do the planning, you need to understand the type of ridge. So whether it is square, tapering, or ovoid. Depending on the type, shape of the ridge, you can plan the number of implants. At the same time, your CBCT, you can see the quantity and the quality of the bone, also the its nearness or farness from the anatomical site. Canine implant site, molar as the key implant site, then we do not have to give three posterior cantilevers to get pontics together and reducing the cantilever. So depending on that, you need to plan your implants.
Okay, the next question is, sir, vertical dimensions are measured from?
Vertical dimension in implantology on the articulator, the vertical dimension is measured from the crest to the occlusal plane. And when you do a jaw relation in a completely edentulous case, the rule remains the same for the vertical dimension as your complete dentures. But if you are doing a space analysis for the kind of prosthesis which you need to give, then it is from the crest to the occlusal plane.
Okay. The next question is, if patient is suffering from any kind of systemic disease, can we do implants on them?
Yes, why not? Depends on what kind of systemic disease it is.
Yes.
So again, systemic disease is a whole full lecture gambit
Mm.
where you need to understand what kind of systemic disease the patient is. But of course, if patient is diabetes, we need to understand the kind of diabetes patient has. If patient is hypertensive, if patient has cardiac problem, if patient has any kind of bisphosphonates, if a patient is having, we need to understand the history of bisphosphonate. So kind of systemic disease can definitely help us understand the implant planning.
Yes.
So whether I have to go for delayed loading, whether I have to go for immediate loading, what are the kind of bone, everything. Systemic, there is no, you can say, contraindication that patient has a systemic problem, so I cannot place an implant. It is what kind of systemic problem patient has, we need to understand.
Yeah. Okay. So the next question is exact how to correct occlusal so implants never fail.
How to correct occlusion so that implant never fails. Okay. So you need to give a cusp and fossa occlusion A and see to it that the lateral forces are reduced with either group function or either mutually protected. And for that, you really require a good lab. So always work with learned technicians who can understand. And as I told you, you can write a whole essay to your lab technician stating that I want this.
Yes.
There should be a communication portal open between your lab technician and a dentist where they come to know what exactly the patient wants.
Yeah.
That is the thing.
The last question is, sir, if D4 bone in mandible, can we use denture burrs? Is there any advantage of using denture burrs over regular drills?
Yes, of course, you can use denser burrs because it's a kind of osteodensification which happens. It does not remove the bone. The bone is deposited there and it's kind of starts expanding. But D4 bone in mandible again can be a weak link because it might be related to some systemic problem. Mandible usually has a D1 or a D2 bone. Maximum it has a D3 bone, but in mandible always have D1, D2 bone in its anatomy. D4 bone can be definitely linked to some kind of osteoporosis or osteoarthritis as well. So you need to revisit your systemic, the previous person who asked it, you need to revisit the systemic problem, why the bone is so soft in mandible. Because D4 bone is like the softest.
Yeah. Okay. There is one more question that do you take any courses or any workshops?
Yes, I do take courses, and so the courses I do it was only for limited number of participants. So it is 4 to 8 participants. If at all you have the data, I can send you the next course brochure. It's I've not put it. Of course, I've not put it on the presentation because it is not right to put it on the presentation. But I do take courses, and that is for limited number of participants. So maximum participants in a course. It is a 3-day course. On the third day, we discussed only occlusion. So this was only a half an hour to 40 minutes lecture. But occlusion, we discuss it in the whole day. It's a 3-day course and a continuous mentoring with, we give clinical, hand holding also. So it's 1 year of mentorship and a 3-day course. Then students perform implants in their clinics. They come back and then they present their cases. And on presentation and a viva, they get a certificate.
Okay, that's great. So maybe attendees, if you want to connect with Dr. Varun Raj, so you can connect it maybe on LinkedIn. If
I am available on Facebook as well as Instagram, so you can connect me there on my own
Okay,
name. It's a public
okay,
platform.
Instagram.
You can
Okay, okay.
definitely get in touch with me and I'll share order details. I'm extremely sorry I couldn't share over here because it's not a platform where I can market myself.
It's okay. Okay, okay. Thank you so much, doctor, for sharing your valuable knowledge with us, and thank you for clearing all the doubts, whether it was basic questions or because implant is the thing, like everyone want to get success, right?
Yes.
Because it is a bit expensive also when in comparison to other dental procedures. So everyone wants, okay, I would need to be perfect. If your implant is perfect, you are very good doctor, you're very good dentist, right? So yes, and thank you for clearing everything, like all according, like what are the occlusion key factors, how to deal with it, what are the challenges that we face throughout this implant occlusion. So you took it very well, and thank you for all the attendees. Thank you to all the attendees for asking the doubts and for attending this valuable insightful session. Thank you, sir, once again.
Thank you very much, man. Thank you very much. Thank
Thank you. Thank you, everyone. Have a nice day. Bye.